Welcome, everybody. My name is James, and I'm a physician assistant. And I've been practicing for over 40 years. I did my undergraduate work at George Washington University. I went to Stanford Medical School for my PA training. I first served in the Navy for 20 years, where I was doing primary care and emergency medicine. Then, after I retired from the military, I started practicing in neurosurgery. And I did that. Well, I've been doing that for over 20 years now. And right now, I'm just working with a lot of pre-PA students, which is why we're hosting this event. So, tonight I have Divya Patel, who was actually a student that I worked with. We do help students get into PA school, and she's going to talk about her experiences. And then helping us out tonight is Maddie, who is now a PA student or future PA student. So, anyway, if you guys want to go ahead and introduce yourselves, then you can take this over.
Cool. Do you want to go first or should I go?
Oh, and I'm sorry, I apologize. One last thing. We will take some questions for Divya later. If you can just hold off on the questions until she gives her presentation. Thanks. So,
You go first.
Okay. Well, my name is Divya Patel. I'm a neurosurgery PA. My pre-PA journey started back in 2017, I believe, when I was second or third year of undergrad, and that's kind of when I discovered the PA profession and fell in love with it for all the perks that it has. And I met James back in 2020, who helped me get me into PA school, and so. For my patient care hours to prepare for PA school mostly came through being a medical assistant in urgent care and OBGYN. Spent a few years doing that and then transitioned to PA school, and neurosurgery was my second rotation in my clinicals. It was really funny because in PA school, we are given kind of a general surgery rotation, but for some reason I landed up in neurosurgery, which I didn't really elect for, or it just kind of happened. And I was like, okay, well, this is great. I get to learn about neurosurgery, but also prep for the general surgery end of rotation exam. So kind of doing two in one. But yeah, I fell in love with it and I knew that's what I wanted to do ever since the rotation. And so I only applied for neurosurgery jobs after I graduated. And so here I am. I love it. I've been working in neurosurgery for a year and a half now at a level two trauma center. And so I've learned a lot of different skills from both of my attendings and also other PAs that I collaborate with every day.
okay. Maddie, want to say hi?
I'm Maddie Shalen, and I just graduated from the University of Wisconsin-Madison, and I've been applying to PA school this cycle, and I've been accepted into two schools already, and I have a few more interviews, so I'm going to be a PA next year. I'm super excited. And I started with James in about last November, and he's helped me through the whole entire process, and I give him so much credit. He's been amazing. And a little bit about my patient care experience. I've been a medical assistant during all of college, and now I'm working in a pediatric specialty office, gaining some more experience while I wait to go to PA school.
Awesome. All right, Divya. I'm going to put up your presentation here. Let me
Mhm.
shoot if I can. Sorry, I had it. Sorry, everybody. Give me a second. I'm okay. You see this okay?
Yes.
All right. So it's on you now.
Okay. All right. So yeah, this is just the neurosurgery shadowing for pre-PA students. We can go to the first slide. Um, yeah, perfect. And so I thought I would kind of just summarize what I do as far as clinic, hospital stuff, and also in the operating room. This can definitely vary depending on what practice you're a part of, but this is kind of a summary of what I do. And so starting with the clinic, this is where I first started when I started my new PA job. They held me in the clinic first, and then while I was waiting to get my privileges for the hospital. So in the clinic, I was able to see new and established patients. So working up neck pain, lower back pain. Sometimes they would come in with brain masses. And so just kind of working those things up, ordering images such as CT scans, X-rays, MRIs. Labs, it's kind of hit or miss. We don't order too many labs. I think the most common one I order in neurosurgery is an A1C, just because if your A1C is above 8, you don't really get elective spine or brain surgery in our clinic. As far as sending referrals, the most common ones I send them to is pain management, PT, and neurology. We can see patients for their pre-op and post-op appointments where we kind of go through, why they're having the surgery, the risks, benefits, alternatives, what their hospital stay looks like, and what their post-op care would look like, and the restrictions. And as far as wound care, we have a lot of patients who unfortunately, well, not a lot, but we have a good amount of patients that unfortunately don't heal well sometimes just because if they're not eating a lot after surgery or if they have diabetes or if they smoke, then their wound tends to not heal that well. So we do a lot of wound care with the wound vac placements in our clinic. As far as the hospital, there's the daily list of patients that we round on. There's new consults that we see from the emergency room. And we can also round on our post-op patients. We can order imaging. We can remove surgical drains. One thing that's really exciting is inserting the external ventricular drains whenever when a patient has an intraventricular hemorrhage. Our attendings have taught us how to insert these at bedsides, of course, like with their supervision. But that's a really good skill that I learned throughout this year. So I was really excited to learn that. And then we can also collect some CSF for testing. As far as the operating room, this is the most exciting one to be a part of. You get to be the first assist. You can maintain visualization of the surgical field, help with hemostasis, secure the wound drains, help with closing. This is the most helpful part where SPAs come into where we can, suture the fascia, the skin layer, and flip the patient and help with the positioning, do the post-op orders. And one thing I wanted to touch on was the Mayfield head clamp. So our attendings have also taught us how to attach the skull in the clamp. So basically, it helps keep the patient really still during our brain and spine cases. There's about 60 to 80 pounds of force that is placed on the patient's head so that it stays really still. So it's also important when you're turning the patient over and removing the clamp, how to handle that carefully. So I'm glad I learned how to do that as well this year. All right, we can go to the next slide. So I also want to touch on the most common type of pain worldwide and something that we always see every day in neurosurgery, which is lower back pain. So I have a little bit of a case study here. So a 73-year-old male with a past medical history of high blood pressure, type 2 diabetes, BPH, and peripheral artery disease presents to the neurosurgery clinic complaining of lower back and leg pain with associated symptoms of numbness, tingling, and urinary retention. So, and he denies saddle anesthesia, acute upper and lower extremity weakness. He reports that his pain started about 10 years ago and has gradually worsened. He denies recent trauma, falls, or accidents, but he worked in construction his whole life. He states that his back and leg pain are worse with activity, relieved by rest, and with NSAIDs. He also states that he has lower back pain that radiates down to his knee on the side of his leg, affecting all of the toes as well. And he said that he also has leg cramps when walking, which is sometimes relieved by rest. So that's a lot to digest. And so when there's a patient with extensive history and a lot of different symptoms that are going on at the same time, it's important to break things down first. So the way that I like to do it is kind of ruling out the red flag signs. So when you're working up lower back pain, the most common thing to rule out as far as an emergency would be cauda equina syndrome. So we see that he complains of urinary retention. He denies saddle anesthesia and acute weakness, which is good. But with the urinary retention, it's always important to look at the history and ask, is it new? Has this been going on for a while? And especially with the history of an enlarged prostate with a 73-year-old male, that also plays a role. So that's less like this is a patient that I wouldn't just rush over to the emergency room, especially if it's chronic. As far as the leg pain, it's important to ask, what's the pattern? Does it radiate down from the lower back? Is it isolated in the hip or the knee? With the history of peripheral artery disease, leg cramping is common. And so he said that he has leg cramping that's sometimes relieved by rest. And with the vascular claudication, it takes about maybe 20 to 30 minutes to, for the pain to pass away with rest. But with neurogenic claudication, I've noticed that patients will say that they sit down and they feel great immediately. So those are some key things that you can ask to differentiate what's causing the pain. As far as the history with type 2 diabetes and lower extremity numbness, again, ask the pattern. Is it one-sided, two-sided? Is it just below the knees in that common diabetic neuropathy area distribution? Or is it radiating downward and following the the pattern of the leg pain as well. And so that's something that you can also ask. As far as things that the patients have tried, if the patient really hasn't tried physical therapy or pain management, insurance is less likely to cover elective surgery. And so if they've just tried resting and maybe ibuprofen or relief, they may need to try pain management with the epidural lumbar injections or physical therapy before this patient can be a surgical candidate by insurance, especially if they're not having any emergent signs. Something else that you can order if you're not quite sure what's causing the nerve pain is an EMG. This can help diagnose neuropathy by showing exactly where there's abnormal electrical activity in the muscles or nerves. So you can kind of pinpoint if this is a chronic nerve damage issue, where it's coming from, but it's only diagnostic, so it won't provide any therapeutic measures for the nerve pain. Alrighty, so we can go to the next slide. So for this patient, I have his MRI here. As far as the physical exam, it looks unremarkable. You know, he was strong in the upper and lower extremities. Reflexes were normal, sensation was intact. And so looking at the MRI, I always like to break it down in a way that patients can understand it so that they get a better idea of also what's going on for their lower back. And so on the left side, right over here, I always like to say, this is an image of your lower back. If we cut you in half and looked at you from the side, this is what we would see. Then I point out these are the bones of the spine. The areas in between that light up white are the discs that provide a cushioning. The wider they are, that means the discs are more hydrated. Most commonly this L4, L5, and S1 area at the very end of our lower back. These commonly go out first, and so we have a little bit of a darker disc and almost like a bone-on-bone picture here. I also point out that we like it when the bones line up with each other, and so they do. But then when we get down to this L4, 5, there's a little bit of an instability that we see, and especially at L5, S1, which is called a spondylolisthesis. And over here, the snake-like figure is the spinal canal. So our spinal cord actually ends at L1, L2 level, and then we just have the thecal sac that runs down here. We see that it's pretty free, but then when we get down to L4, 5, and S1, there's some pressure that goes out to the nerve roots. And also on the axial view, I like to tell the patients right over here, this is an image if we kind of cut them like a loaf of bread and looked at them in slices. So their legs are down here, their head's up here. This is the right side and this is the left side. So it's kind of flipped over because we're looking up into the image. So I like to point out that. And we're able to see on the axial view exactly what side of the nerve root is affected. So it looks like it's impinging a little bit on both sides, but a little bit more on the left, I would say, right over here. And also there's some arthritis within the facet joints. And so this is important to point out because this is a direct cause for lower back pain because you have nerves that exit out of those facet joints. And typically, our patients see pain management for something called a radiofrequency ablation if they're just having issues from facet arthropathy. So typically, if I see a patient like this and they don't need any emergent surgery or intervention, I'll order an X-ray, the 4-view X-ray with the flexion extension views. And that basically will have the patient bend forward and backward to see if there's any type of instability in their spine. I'll send a referral over to pain management for the epidural injections, send a referral for aquatic physical therapy. I like the aquatic one because it kind of allows for pain-free physical therapy, working against the buoyancy of the water in the swimming pools. And so sometimes our patients don't like it. Sometimes they have a pool in their backyard, so they kind of look up their own things to do in their own pool, which is fine with me. Or sometimes if they want a little bit of formal physical therapy, that's also an option. So I'll send a referral out. And then I'll have them come back and see me in 2 to 3 months to see how they felt after the injection, trying physical therapy with the x-rays. And so this patient came back 3 months later without any symptom relief. And so pretty much we can see that on the flexion extension views, there's some abnormal movement between L4 to S1. The bones don't quite line up with each other here or here. All right, we can go to the next slide. So once they've tried everything, there's abnormal movement. We start talking about a lumbar fusion surgery. So one thing to point out is that a lot of patients or people will think that back surgery is intended for lower back pain, but that's not the case. It's intended to take pressure off the nerves that radiate downwards to our legs to help with leg pain. Because the surgery itself, we dissect a lot of muscles and we do the surgery in the lower back. There always will be some degree of back pain, especially in the first 3 months. It's really bad. And then even after that, because of the chronic degenerative changes, the patients will always have some degree of lower back pain. But the intention of surgery is to take pressure off the nerves to stabilize the spine so that their legs will feel better. And so that's exactly what we do. So we take pressure off the nerves. We scrape out the disc that's causing the issue. We put in screws and rods to stabilize and support the spine while the fusion takes place over the next year. So some patients think that the fusion is, post-op day one, but that's not the case. The first 3 months are the most critical, and then we wait the whole year by ordering imaging, emphasizing a diet high in protein. We recommend at least 100 grams a day. Quit smoking if you're a smoker, work on the diabetes and osteoporosis if that's in their history. And then, yeah, we get imaging, see how they're doing. And typically patients heal well if the surgery is successful with the fusion, with the dietary intake. And so, yeah, these rods and screws stay there forever. The ones that we use are made of titanium, so they can still have MRIs and they don't set off the metal detectors in the airport or anything like that. Another big thing I wanted to point out was we don't recommend any patients to be bedbound after this type of surgery. We encourage lots of walking. The only restriction they have in the first 3 months is no lifting more than 5 pounds and no BLT, no bending, lifting, or twisting. And then we have them in a back brace for about 3 months after their surgery, just when they're out of bed. All right, yeah, we can go to the next slide. All right, so this is the second case. So this is the patient who had a decompressive craniectomy done, which is a removal of the bone flap. And I wanted to include this picture because I don't think this procedure is done that much anymore, but I thought it was pretty funny because it kind of looks like he swallowed the bone flap, but that's not the case. They just put it right under the skin so that, when you remove the bone, it travels with the patient, doesn't get lost. And when it's time to go, put the bone flap back in, you know where it is. But these days, when we remove the bone flap, we send it to a third party company that provides freezers. I think we use one in Canada or the East Coast. And when it's time for the patients to have it reinserted, we call them, they sterilize it and defrost it for us, and they send it back to our hospital. And we have like this 24-hour period where we have to put it back in. All right, we can go to the next slide. All right, so this is a patient who had a craniectomy done, so we can kind of talk about her history, what brought her in, and why we did the procedure. So, a 36-year-old female brought in by ambulance, sat as post-motor vehicle accident, came into the ER. She was unresponsive with anisocoria, which is unequal pupil size. So, a lot of people freak out about anisocoria, and sometimes, it's because nothing, it's, not because of any emergent cause. It could be because of a medication side effect, eye trauma, or it can also mean impending brain death. So it's important to look at the history and the presentation of the patient. So in this case, she was, there was trauma involved. She was brought in by ambulance. And so, we always get a head CT first emergently. And so we look for a bleed, tumor, or swelling that could be causing pressure on the brain, causing the unequal pupil size. And so with her case, we saw that there was something called the uncal herniation, where she had a traumatic subdural hematoma causing about 8 to 10 millimeters of shift, I believe, and it was pressing down on the brainstem. And so with the uncal herniation, the brain swells because of a bleed, and it compresses the brainstem in her case, and it was pushing on cranial nerve 3, which constricts the pupil and also helps with a little bit of eye movement. And so by pressing on that nerve, it caused the same side of the herniation to have the pupillary dilation. We can go to the next slide. And so I have a normal head CT scan versus the one that was shown for our patient. And so on the normal head scan, we can, just some quick things to point out. It's important to see the differentiation between the gyri and the soul side pattern. So that means that when we can see the grooves of the brain, there's not abnormal pressure in that side. We also like it when one side of the brain matches the other side of the brain. And so we can see that on this picture, of course, but not this one for the patient. And there's also a midline shift. meaning that there is either a bleed, tumor, in her case, a bleed on the right side of the brain, right over here, that's causing a push and a shift. And so we can measure that shift. And usually, if it's more than 10 millimeters, that's an indication for surgery. So what we did was we took out a piece of her bone right over here. And the rule that we usually go by is we want to take out the size of our hand. So we take that big of a bone, part out of the skull, and we allow the brain to swell up. So that's the intention, to allow the brain to swell upwards so that it doesn't press onto the brain stem. And so we let the brain swell upwards. We monitor the patient. If they do improve, which is sometimes it's just hard to tell the prognosis sometimes, but if they do improve, within 6 months to 1 year post-op, we can reinsert the bone flap. And so that's something that we routinely do after we send it to the freezer, and then we bring it back to our hospital for sterilization after it's sterilized and thawed, and we replace it. We've had cases where sometimes the patient comes back after the 1 year mark. Unfortunately, the bone flap is no longer sterile after that point. So we have to use things like a titanium mesh or bone cement, which is pretty cool, but not ideal.
Have you guys never used a prosthesis? Or have you done that yet?
I've heard they're really expensive. So I think that's,
Yeah, but I mean, um, you just get a fine cut CT and then the company will cut it. They'll use the CT to cut it, and it's like a puzzle piece. It's amazing when you get it; it just fits perfect. And then you just
we'll
use
have
the
to look
little
into
dog
that.
bone plates to attach it, and you're done. But I've done bone cement, but I would never do it again. I would always, and I mean I've had people on Medi-Cal get it. So I
Oh,
mean I
really?
know,
Okay.
yeah. So I would always go for the prosthesis. But anyway,
We'll have to look into that. Seems like a good idea.
it is.
Well, yeah, that's my presentation. Is there anything that, you guys wanted me to talk a little bit more on or?
No, I mean this is usually have questions at this point. So just open this up to anyone who has any questions that they want to ask. And why am I not, shoot, where am I?
I don't see any questions yet.
I know, and oops, sorry. Trying to remember. God. Um,
Oh,
oh,
here.
there. Okay. Sorry. Here we go. All right.
All right. The first question from someone anonymous, where's your practice located?
It's located in Sutter Health in Modesto. So we are contracted with Memorial Medical Center in Modesto. So we are part of the Gold Medical Group.
The next question is from Pooja. Can you do your surgery like minor ones?
Mm, we minimally invasive options, I'm assuming. We do microdiscectomies, which are our most minimally invasive options. So we do it either endoscopically, where we make a really small 5 millimeter incision and we go through a really tiny tube and take the disc out that's causing issues. Or we can also go through another option with these bigger tubes. But yeah, the endoscopics are the least minimally invasive.
Do you ever do ventriculostomies? Have you done those yet?
I have not, no.
Okay. Tell them to teach you how to do a ventric.
Okay.
I used to do those down the ER.
Oh, okay, cool.
I mean, you've seen them before? You've seen ventriculostomies or
No, I haven't. No.
just for monitoring intracranial pressure, it's just a drill that you do bedside, and then create a hole through the skull and then just pass a ventriculostomy catheter down into the
Oh,
brain, try to get it into the fourth ventricle, and then you're using it to drain off some of the CSF, but also measure ICP.
oh, so I guess I've placed external ventricular drains before.
Right.
So
But
that's similar concept a little bit.
yeah. But you can do these right bedside in the ER. So they used to, I mean, I had to do like 4 or 5 before they let me do them on my own. But
To use
sorry.
the hand drill or the electric drill?
No, you do use the hand drill.
Hand
There's
drill?
no, yeah, there's no, you definitely don't do a power drill unless you're in the OR, but no, a
Yeah.
hand drill because it's got a stop on it. So as you go through the outer table and you're going through the skull, and you can put a stop on it so you don't plunge through the inner table, the cranium. But yeah, you definitely want, it looks like a 1950s drill, but that's the one you want to use. So
Okay, cool.
All right, the next question's from Halima. How did you become a medical assistant during undergrad and what hours did you work?
The way I became a medical, I wasn't certified because that took too long, in my opinion. It was expensive. And so I found a doctor who would be willing to train me in urgent care. And so I just kind of, started front office and then started learning the back office duties. And so I was trained under him. And so I think urgent care is a good place if you can find someone who can train you, be much more quicker than doing formal, the training process for the medical assisting, especially when you're an undergrad where you don't have too much time. But my hours, I worked, I think 1 8-hour shift on the weekends or two 8-hour shifts on the weekends, so it wasn't too bad either.
All right, another question which is going off of that is I'm getting my CNA license soon. Is that good experience if I'm interested in PA school or should I pursue a medical assistant license too?
I think that's a pretty decent experience too, because you get a lot of hands-on experience. You learn a lot about the nursing side, which I feel, as a medical assistant, and working as a PA, it's nice to know exactly what the nurses can do, what their role is. So I think CNA would be a really good route, especially if you're planning on inpatient care as a PA.
And to build off that, I'm just my experience. I got my CNA license, and I worked as a CNA, but I also worked as a medical assistant. So some offices will hire you as a CNA and you can be like a patient care tech, which is basically the same roles as like a medical assistant. So I would get it if I were you. The next question is, what helped you build your candidacy for PA school in neurosurgery?
I would say for PA school, James, of course, played a big role in helping me get into PA school. So finding a good mentor definitely helps because, there's someone there to kind of double check what you've done and maybe touch on things that you should do before applying. So that was a huge help, especially with the interviews. As far as neurosurgery, it's kind of, if you don't have any experience, that's also a bonus, just so that the neurosurgeons and attendings can train you the way that they would like you to practice. And so having the rotation in PA school was great, but also finding really nice attendings who are willing to train and yeah, and I think that was the main thing. I don't think we've hired just two other new grads as well. And so yeah, I think there's no formal training that's needed to go into neurosurgery. Maybe a rotation in PA school if you can.
Is there close monitoring with the patient after their craniectomy while they wait for the inflammation to go down?
We see them every month for the first 3 months. And then at that 3 month mark, we order a repeat head CT to see how their brain looks, if the swelling has gone down, to see if they're a candidate for the bone flap reinsertion. And so if they are, then we book them for a surgery.
What is your favorite thing about practicing as a PA, and what is the most challenging thing about practicing as a PA?
I think my favorite thing is, every day is different, and there's just so many different people that I meet and impact that I make in different ways in people's lives. And so, especially with neurosurgery, you see everything under the sun. And being a neurosurgery PA, I think the sky's the limit. There's just so much you can do under your license working in neurosurgery. And so I think that's really exciting. The most challenging part is the specialty in itself. It's a beast. I mean, you're not taught neurosurgery in PA school. And so there's a lot of different concepts and learning, but it's really fun too. But I think the main thing is finding a team that's willing to support your learning and helping you protect your license, especially in your early stages.
Would you say most of your training came from rotations, or was there a good amount of learning on the job as well?
Yeah, definitely on the job. I think when you're a student, unfortunately, you're like the last person that gets to scrub it or even do anything besides watch. So you get a lot of good information from the rotation, maybe about interpreting imaging and that kind of thing. But all the hands-on stuff comes when you start working.
You talked about pain management and other referrals. What about chiropractic referrals and how can that affect spinal treatment?
That's a good one because, the chiropractors, we love them for the lower back, don't quite like them for the neck. I never refer to a chiropractor if any of my patients are having neck pain just because the risk of a carotid artery or vertebral artery dissection sometimes when manipulating the neck. And so for lower back, we love it, or, we don't mind, but for the neck, we don't recommend chiropractors typically, unfortunately.
Pooja asked, is this without physician supervision?
For the referrals.
No, a separate question.
Mm. Oh, and regarding just like practicing as a PA, um, I guess you definitely work under the physician's supervision. I would say that we're able to see our own patients in clinic, but also having the awareness that if we're not sure about certain decisions, that you can, call them or see if they're in clinic to ask them or follow up with the patient later. But yeah, we're always working under the direct supervision of our attendings.
Why did you choose to specialize in neurology? I think
Uh, oh, yeah, neurosurgery.
straight they meant.
Yeah. Well, I loved it. I thought that, it's very exciting and different to be in this type of field. You learn a lot of different skills, and, there's only a handful of people out there that will have this skill set. And so I don't know. I just thought it was really unique, exciting, and every day was different. And I love the continuity of care also because you get to see patients in their pre-op phase and then after surgery, a lot of them, heal really well. And so it's nice seeing that you're able to relieve some of their arm pain or leg pain or really help them in life. And so I really like that continuity of care and making a difference and seeing the patients throughout every stage and even being in their surgery sometimes.
Nawa, I hope I said that right. How is the note taking when you, as a PA, assist in surgery?
The note taking.
Yeah,
Mm,
maybe like charting, she means.
Yeah, no,
oh.
I mean, I would just, as a PA assistant neurosurgery, you're listed as the first assist. If that's, I'm not sure if that's what she was asking.
We can see. We'll go to the next one. Brianna, what is the most challenging case you have been involved in?
I think the most challenging ones is when, it's a pediatric patient, there's traumatic brain injury, the end of life picture. It's just,
Mm-hmm.
those are the most challenging ones, just because, sometimes you're delivering the bad news, sometimes you don't know the prognosis, and, there's all the questions that, the parents have, and sometimes you can't provide all the answers, but just your support and comfort. And so those are the most challenging ones. Luckily, we don't get them too often just because we don't do pediatric neurosurgery, but sometimes the emergency cases come in where we have to. But it just comes with the field. And the more you do it, the more comfortable you get. But just, yeah, those are the most challenging ones, I think.
And then back to the note taking when she meant charting. She chatted that.
Oh, charting. So we don't do any of the, I guess if you're asking about the operative notes and things like that, we don't do any of those. The most charting that we do during surgery, I mean, would be after surgery when I do the post-op orders and the discharge summaries and those type of things. So it's not too bad at all.
All right. What are the hours you can expect from this specific field? Is there on call?
That's a good question. So at my work, we don't do primary call as PAs. Our attendings take primary call. We are on call 3 weeks out of the month, and there's only two of our attendings, so it does get very busy. But us PAs, we are full time, but we only do the day shift. So we're only 8:30 to 4:30 Monday through Friday. So it's really nice. But when it's really busy, of course, we all step up and we, stay a little bit longer. So sometimes I'm there until like 6:30 or 7. We work every other weekend, so we take off time during the week when we can. So just depends. Just depends on the role. But yeah, the biggest thing is work-life balance as PAs. I think that's one of the perks of why we go into this field too. But just, if you have a team that supports that and takes care of each other. So when I work the weekend, I take one day off during the week and my partners will cover for me. And so just having that communication with them and we, make sure everyone's taken care of. And we try not to work more than 40 hours a week, but that doesn't always happen.
Miranda asks, what made you choose to become a PA instead of another healthcare role?
Well, the PA career kind of, lets me do what I love doing quickly. And so, undergrad and the PA school is really rigorous, but it's just much quicker getting in the field doing what I love. And so that's why I chose this route.
And your father is a physician.
My dad?
Yeah.
No, no, I
I,
was the first person in my family to go in the
oh,
medical
I'm
field,
sorry. I thought he was. Okay.
but he said something.
Yeah, I remember what he said.
Yeah.
No, I remember that. That's why I was saying that. Okay.
Yeah, no, yeah.
And then what made you interested in being a PA? I'm currently thinking about PA school, and why did you choose neurosurgery? You kind of elaborated on this already.
Yeah, and so it's just a quick way to get started doing what you love doing. There's also lateral mobility. So sometimes, you might graduate and think that you, I don't know, want to do urology, but then you don't like it. And you can always go into the ER, urgent care, primary care. You can go into any specialty of the PA. So there's lateral mobility. And so sometimes switching specialties is what people like to do. But I'm lucky that I found something that I love and I can't see myself doing anything else. I think take advantage of rotations in PA school. If you haven't found your interest yet, you can go through and pick different electives when you get there, and so that can be something good to explore and kind of figure out what you like.
David asks, in the case of doing a craniectomy, is there anything that is done to protect the part of the brain from further trauma?
Yeah, it's a good question. We usually get a helmet for these patients, so they wear a helmet, at all times when they're out of bed, typically, until we can reinsert their bone flap.
And don't
Is
forget the sign above the bed.
Oh yeah, oh yeah. No bone flap sign above the bed.
Yeah.
is PA certification valid worldwide or only in the US/North America?
I think it's valid in the UK and is it in New Zealand, I think?
No, actually, it's just the United States. So it's not, I can't use it in Canada. So
Oh, I
they
see.
do have PAs in the UK and Germany and Australia, but our license or certification, our training carries over. You would just have to go through, the licensing procedure over there.
The procedures you mentioned, is that done inpatient or outpatient? And then do you usually work inpatient or outpatient?
Lumbar fusions can be inpatient or outpatient depending on how the patient presents. But as far as craniectomies, these are, usually associated with some type of trauma. So they're more inpatient or only inpatient. And I work both inpatient, outpatient.
Michaela said, how is your role different than a surgical assistant or an OR nurse while in surgery?
Yeah, that's a good question too. So I would say the OR nurse, the RNFAs, which we commonly use too in the surgeries, they mostly just do the intra-op things. But as PAs, we can go around on the patients pre-op, post-op, see them in the clinic, and that's something different than what they can do.
Well, additionally, I mean, in surgery, the PA can do the opening, can do the closure, but this is something an OR tech cannot do or surgical tech cannot do.
Brianna asked, how do you divide your time between the OR and clinicals and other tasks?
It's a little hard sometimes, when we're on call and flooded with new consults and sometimes you'll go the whole day, without eating or drinking anything, which is fine. But I don't know, a lot of humor, just, making, having a good relationship with my other PAs that I work with, because we'll split the task up, we'll split up rounding and things like that. So if you have if you have a well-rounded team that's supporting you, it's great. But sometimes, it's hot and cold in neurosurgery. Sometimes there's nothing, and sometimes everything's going on. So it's just being flexible and adapting to the day, whatever that may look like.
Azul asks, if the person who received the craniectomy hit their head before getting their brain flap placed back, what would be the next steps?
So if they were already, if they're outpatient, they hit their head, we can see them in the clinic urgently, depending on how their neurological status is. But if they are having deficits, then we usually recommend just going to the ER for a stat CT to see if they redeveloped a bleed. But if they're stable, not having too much pain, and it wasn't, a bad fall with a head strike, then we can always just see them in clinic. We can order a stat CT outpatient and just kind of monitor either way. So just getting maybe a more idea of what the history was, what the fall was, and then we can guide the patient either to the ER or an outpatient stat CT.
Saida asked, how did you prepare for surgical rotations as it may seem daunting in PA school?
Yeah, they're pretty, it's kind of nerve-wracking to go into it the first time around because you're learning all the nuances of scrubbing and don't be too hard on yourself if you contaminate yourself, especially when you're in rotations, it's bound to happen. But I think every school should have kind of a rotation on what to expect in or a class on what how to scrub in, how the OR works, what to do if you need to sneeze or cough, that kind of thing. So you can ask one of your professors in PA school. They would be able to help you out or watch YouTube videos of how to scrub in and maybe practice getting extra gown and gloves from the OR and practice at home of how to scrub in.
How many patient hours did you get before applying to PA school?
I think it was 3,000 something hours, 3,000 or 4,000.
How does your schedule, mm, how does your schedule look each week with day-to-day tasks with pre-op and post-op patients?
I guess so. Right now, the other PA that I work with, him and I, we kind of rotate the week. So one week I'm in clinic, the other week I'm in the hospital. And so it just depends, again, being flexible. So just because I'm in clinic and he's getting, he has a long list of patients to round on. I can always go in if I have some downtime and scrub into the surgery and help out or see some new consults or round on some patients for him. So just having a very good communication with my partners and just being flexible. So every day is different. There's a lot of things that, we know our schedule for the day, but then we might get some emergency people that need to be seen, even in the clinic side, that are having issues. And so just depends. It's kind of hard to say. There's not really, it's not always black and white with my schedule.
3,500 hours.
Yeah. Oh, was it 3,500?
Mm-hmm.
You can look that up so quickly.
I know.
Good records. What can I say?
Did you take the GRE? What was your study process?
I don't think I took the GRE.
No.
No, yeah, no.
Mm.
Um, what was your major for undergrad, and do you have any advice for undergrads so they could prepare well for PA school?
I went to UC Davis. My undergrad major was human development. And so that kind of touched, our motto was funny. It was from the womb to the tomb. So it kind of touched on prenatal all the way up to the geriatric population. And so it covered some of the core classes I needed for PA school, but then I also had to go back and do some other courses. So I think your major can be really anything. It's easier if you have a major that's more dedicated towards the science, so you can get a lot of the prereqs out of the way, but it could be anything as long as you complete the prereqs and do well in them.
And then how quick do the rotations for PA school go by?
Very fast, very, very fast. So our rotations were only 3.5 weeks, and then last, week or last few days of the rotation, we'd be studying for the end of rotation exams and doing those things. So it goes by really, really quick.
What was the hardest thing you experienced throughout PA school, and how did you overcome it?
Yeah, I think the didactic year by far was the hardest year, but I think just, giving yourself grace to work out and, spend time with family whenever you can. I mean, you're busy studying, but maybe just dedicating maybe like a few hours in the week just to do things that you love or half an hour every day and to not lose that self of yourself. And so that side of yourself. And so but yeah, it's rigorous, but it's just one year and you get through it pretty fast and you lean on your, other people in your cohort, for support and your professors. But it is hard, but it goes by really fast.
Would it be worth it to do a fellowship for neurosurgeon instead of just jumping straight into it?
That's a good question too. I don't know how strongly I feel about doing residencies, especially for, as a PA, just because if you do it at, what's it called, like a university-based hospital, then you have the residents,
Yep.
you have fellows that take priority over you. And so I don't know how much hands-on you'll be or what the learning process of that looks like, but I think just finding a surgeon who's willing to teach you, it's the best. It's personally, in my opinion, the best way to go.
Mhm.
What does your work-life balance look like?
Yeah, like I said, we try not to work more than 40 hours a week, but sometimes we do. We work every other weekend, and so that, as we get more help, we're going to work less weekends. That's the plan. But as of right now, we work every other weekend. So just finding time throughout the week to take off. And but yeah, as a PA, and once you're done with PA school, you'll learn that the work-life balance seems a lot better when you're in PA school. Everything's just constantly studying and that. And so it gets better, but it is what you make of your career. If you want a specific work-life balance, then you have to communicate that, to the other PAs that you work with and find a job that kind of supports your growth too, because you can't just burn out in your first year. You need that support from your team as well.
What did on-the-job training look like for neurosurgery?
Well, because I was also a new grad, they kind of put me in the clinic first for the first 2 months. And then as I was waiting for the hospital to work on my credentialing, I worked in the clinic. I saw our pre-op patients, post-op patients, saw established patients. Usually I saw the ones that were, in their 80s and 90s first that weren't really surgical candidates, but just kind of learning more how to talk with patients in the neurosurgery setting. And then they kind of let me go into the younger population, kind of working their neck pain and back pain up and advancing me as they thought was appropriate. And then I moved to the hospital, and then I just did that for the the rest of the 8 months or whatever in the year. And that's a whole different beast is learning the hospital way of how things work and how
Mhm.
to speak with different specialties and get things started for the patient. So it takes a long time, but I had a really great support system too. So.
As Ether asked, do you feel like being a PA in neurosurgery has felt limiting in regards to wanting to provide any care that you may not be able to?
That's a good question. I guess it's so specialized. So sometimes patients with general medicine, they'll ask me like, if I can prescribe them, blood pressure medications or
Mhm.
heart medications, other things. Unfortunately, I can't just because not that I don't want to, it's just because I can't monitor their progression and, do their refills. So I guess it limits the type and the amount of different medications I can prescribe. I usually only, see myself refilling muscle relaxers and pain medications. So I guess for the general medicine wise, it does limit you.
What do you think distinguishes a great neurosurgeon from a good one, both inside and outside the OR? And then a follow-up, as a nursing student interested in becoming a PA, what steps would you recommend I take now, academically and clinically, to strengthen my application and prepare for the transition?
I think the difference between a great and a good surgeon, I think a surgeon who tells you realistically when you need surgery versus when you don't need surgery, who's not really always pushing for surgery,
Mhm.
that's good to see. Because sometimes patients can heal without surgery. If the herniation is not too small, they can try I mean, if it's not too large, they can try physical therapy and that type of thing. We have seen clinical and radiographic improvement with these type of measures. So knowing when to cut, basically. And as far as nursing to the PA route, I don't know, I would think nurse practitioner might be a little bit, more towards your route if you already have a pre-nursing background or a nursing background. But as far as nursing to PA, you just need to get a bachelor degree, do the prereqs. Um, if you're a nurse, the patient care hours will work for the application and you just apply to PA school.
When you have patients to see in the clinic, do you see the patients alone or does the doctor have to go in and see them afterwards as well?
Some places, I know the PAs will do the initial history and physical exam, and then the doctors will come in and discuss their plan further. But at ours, we kind of just do everything from the start to finish. Sometimes the surgeons, if they're available in clinic that day, and if it's their patient, they'll pop in just to see how the patient's doing. But generally, we see our patients from start to finish.
What is the most difficult and best aspect of being a woman in neurosurgery as a PA?
That's a good one. I think, yeah, James and I were kind of talking about this back in the day when I was first applying for neurosurgery jobs. And, with women, um, sometimes surgery teams are kind of, I don't know how you would phrase this, would shy away from hiring, or
Yeah,
we talked about the whole, with
reluctant. They're reluctant.
reluctant, yeah, to hire just because, the whole family,
Hmm.
getting pregnant and family planning and
But
all that kind of
you have
stuff.
to because of the X-ray. Because
X-rays,
there's so
yeah.
much there's so much X-ray going on during surgery that once you're pregnant, can't be in surgery, because of
Yeah.
all the radiation.
Yeah. There would be a lot of, going in and out, and I think that would be a little bit too excessive too, especially
Right.
with
And yeah,
too. And so that's one thing. But other than that, I haven't really seen any downsides or anyone looking down on me for, being a woman in neurosurgery. And so yeah.
Do you use medical scribes?
We do not, but Sutter is coming out with this AI scribe. I don't know if you guys use it, but that's something different that they're trying. So I might be using that soon.
I will not be surprised if scribes just go away. I think AI
Yeah.
is going to eliminate the scribe position.
The office I work at uses, it's called the Abridge device, and
Right.
it records it all and types their
Yep.
notes for them.
Yeah. So if you're looking at a scribe job, it might be gone soon. So
Yeah.
Um, did you pick this field out of PA school or were you selected for it? Like how pre-meds have that ceremony where they find out where they were selected to go.
No. So that's something with PAs. We can pick our specialty once we graduate. It's not that we match into a certain program or specialty.
I'm a first gen student and the first person in my family to take the medicine route. What tips and tricks do you have for students like me?
I was in the same boat as you. I've never had anyone, be in the medical field in my family. So kind of pioneering the way, which is fun, but also finding different people who can support you because it is a different world in medicine. Just, how everything goes. And so I think finding a good mentor and, wherever you work, just leaning on the doctors or your higher ups to see their thinking process and how they do things.
Like what we kind of just said, where do you see the use of AI in the future of PAs?
I know a lot of people have told me that, I'm gonna lose my job to AI, but I don't know how true that is. I don't think so. I think that with um, PAs and with AI, I think it hasn't really made, I don't know, I don't see it making that big of an impact where they can take the jobs of PAs. I think it's more so for the small things where right now in our office we have something that generates a message. So let's say a patient will send us that, my incision, it's red and hot and tender. There's some drainage, and so it'll kind of make a little script for us, saying like, oh, well, I can prescribe so and so antibiotic course for you and come in as, on this next appointment day, we can see you. So it kind of generates messages for us, but I haven't worked with AI that much where it does anything else.
How long do surgeries usually take?
Depends on the case. So sometimes we do our cases that are like T10 to pelvis, which can
Mm.
take, where we do 2 days worth of surgery. Sometimes the one level cervical fusion, which just takes an hour, or even a VP shunt, which takes like 45 minutes. So
Mm.
just depends.
When would you work with or refer to an orthopedic spine surgeon?
Um, I don't, well, I work with attending who did a complex spine fellowship, so I don't think that we would refer necessarily from our practice to orthopedic spine.
What do you wish your younger self had known before pursuing a career as a PA?
I think that, I definitely, if I had known in my early high school days, I would have done more shadowing, I think, and just kind of getting a head start on the medical, what it takes to be in the medical field. But I think that where I started was pretty young too, when I was 18 or 19. So I thought I had a good start. But yeah, just kind of leaning more on getting a head start on biology, probably in my earlier days.
Going off of that, what advice would you give to a student applying to PA school this cycle?
Um, it's going to be hard. You might get, a handful of rejections, but keep going. It just takes one.
Mhm.
And then when you get accepted, it's all worth the wait.
Tegan asked, do you make yourself seen and heard as a PA student in clinical and rotations?
I think just being curious and asking the right questions, definitely, and showing that you're interested in the field. One thing that my mentor in PA school told me was, just fake it till you make it. The more you can, ask the provoking questions and seem like you're curious, the more information you might get from your attendings and the more they'll be willing to teach you. If you're kind of quiet and don't ask a lot of questions and just, kind of stand there and you're absorbing everything that you're hearing, but then the more interested you seem, I think that they'd be willing to teach you a little bit more too.
Um, what PA school did you go to? So far, every PA school I see requires the GRE.
I went to George Fox, so I'm not sure if they changed their requirement recently, but when I went there, they didn't require the GRE.
How does one keep a soft, empathetic bedside manner when everything is so pressurized and quick during rotations?
Yeah, again, kind of just have to keep yourself composed and one thing I've learned from our surgeons is that, when you're in a high leadership position, everyone kind of looks at you for the plan. And if you start freaking out, then everyone starts freaking out. And so as best as you can, just calmly think about the plan, what needs to get done, and try not to focus on all the chaos.
And just real quick, I'll go back to the GRE. There are 338 programs, and less than one third of the programs require the GRE. So over two-thirds do not require the GRE.
Yeah.
What was your undergrad GPA?
I don't think it was that good. I think it was like around a 3.4, I think, if I'm not mistaken.
Anissa asked, how long did it take you to get your PA prereqs at Davis while doing human development? I'm doing the same at Davis, so I'm curious if you have any tips.
Oh, wait, sorry, let me see that first part. So she's at Davis right now. How
Yes.
long did it take you to get your prereqs?
Yeah.
I would say around 2 to 3 years. For all the prereqs, there's a lot of different schools that require, like microbiome versus some schools might require just like that one outlier class. And some require Spanish. So just depending on how many classes you decide to take, besides the majority, can take maybe an extra semester but it shouldn't take more than 2 to 3 years.
Okay. We're gonna take just a couple more questions because we're basically at the hour limit. So we'll go ahead and
Did
hit
you
a
take
couple
a
more.
gap year between college and PA school?
I did. I took, I believe, 2 gap years where I just kind of was working as an MA.
Have you ever encountered a patient yet who said they would prefer to see the doctor instead of a PA? If so, how
All
did you
the time.
handle it?
All the time. It's fine, I take no, I don't take in the wrong way. I just tell them, well, the doctor, he's either in surgery or busy in his clinic. Happy to reschedule. If they really want to see the doctor, happy to reschedule, but sometimes they're booked 2 months out. And so I just reassure them that, I've had their neurosurgeon review the imaging and we've discussed the plan, and then they feel a lot more comfortable after knowing that.
All right. What advice would you give to someone whose GPA isn't as competitive as it should be, but everything else is very well rounded?
Yeah, so that's kind of the same boat I was in, where my cumulative GPA wasn't that high, but the last 60 units were. And so that's something that the school that I applied to really looked at was the last 60 units, which kind of shows the type of student that you are in the most recent years versus the cumulative GPA. And so just maintaining a good GPA in the last 60 units and just being well-rounded. And I think the interview is one thing that really helps you get into the school once you can get that, showing your personality and really focusing on the mission of that program and making sure you align with it.
Okay. I'm gonna do the one last question. So Penelope was asking, you talked about doing CSF collection. So as a PA, do you do the actual procedure?
We can. So we can put in the external ventricular drain and we can collect CSF that way for testing. If there is already a drain that's placed in, it's a lot easier. You can just take, make sure everything's sterile. You can open the tube and collect CSF. Sometimes you might even need to tap a shunt, which I can do as well, which my attendings have shown me. But the key thing is just to make sure everything's very sterile.
I think what she's getting at, like as a PA, or like, can you do a lumbar puncture?
I'm sure you can as a PA. I don't. Neurology
Yeah.
does them. Yeah. But yeah, you can.
I mean, I've been able to, and we just, again, it's one of these things, generally in a hospital setting, you probably have to do like about four or five, have them signed off, and then you'll get hospital privileges to perform that procedure. But, PAs are able to do lumbar puncture for CSF collection.
James, you have many years of experience.
Yeah,
Yeah.
I know. You've been doing this for what, a year now, Divya? So don't worry, you will. All right. Okay. Well, again, I know there's a lot of questions. We had this happen last week, and I'm sorry, but trying to respect everybody's time here. So appreciate everybody that attended. We should have another one coming up well, we do. We have another one coming up at the end of this month. I think it'll be 2 weeks from today. So I guess the 27th of August, we'll be doing one with an ERPA who works I think she's in Pensacola, Florida. But anyway, thanks for everybody attending tonight. It was good time. It's interesting to hear from somebody else doing this job that I've been doing. And appreciate your time, Maddie, as well. Thanks a lot for helping us out. As I said before, we'll be sending out certificates to the people who attended. So just give us a day or two and we'll get these in an email to you. But thanks again for all those who attended and have a nice evening. We'll see you again in a couple of weeks if you want. We'll put up a link in Instagram for those who want to attend the next event. We should have that up by the end of this week or early next week. All right. Thanks again, everybody.